Jackson had an absolute, total, and thorough inability to sleep.
I'm here to get justice for Michael Jackson.
Your Honor, I'm an innocent man.
He was not an anesthesiologist. He was not board certified in cardiology. Conrad Murray was not board certified in any medical specialty. Michael Jackson's death was a homicide. Revive Mr. Jackson, is that accurate?
That would be accurate.
Okay. And throughout those conversations...
Dr. Cooper, on Friday, you described your activities on June 25th, 2009, from the time of approximately 1:13 thereafter, in your attempts to revive Michael Jackson, the decedent in this case. Do you recall your testimony?
Yes.
Okay.
The beginning of the
And
trial,
I believe
day
when we left off,
5.
We've gone through some of the photographs of the trauma bay, and you had also indicated that you had had conversations with Dr. Murray upon Mr. Jackson's initial arrival, as well as throughout your attempts to revive Mr. Jackson. Is that accurate?
That would be accurate.
Okay. And throughout those conversations, what he indicated to you is that he had given Michael Jackson a total of 4 milligrams of lorazepam. Is that accurate?
That's what I was told, yes.
Okay. And no mention of propofol.
No,
That's correct?
that is correct.
I wanted to follow up just very briefly with Mark Peoples' 48 for identification. May we dim the lights just for a moment? Please. Vincent, thanks. Good point. Dr. Cooper, what is this item here to the right of the equipment cabinet that has the pole and then a rectangular device on top of it?
That is a small ventilator.
Okay. And I don't believe I'd asked you on Friday, what is this stand? This stand here to the left of the photograph has a pole and then two separate poles coming up from that stand.
Those are two IV poles, and on them, these are sort of like small computers. They're pumps to control the rate of infusion if you had an IV bag attached to the pole.
Okay, those are computerized infusion pumps?
Yes.
If you have an infusion line, they can be programmed to control the rate of infusion into the patient?
Correct.
The lights can be on. Thank you, Your Honor. Now, in regard to your efforts to revive Mr. Jackson, you've described some of the team members that were present. I believe it was 14 people and additional individuals coming in and out. Is that accurate?
That would be accurate.
Okay. As far as resuscitative drugs, was there a process of different drugs that were given to Mr. Jackson during these procedures?
There were. I was managing the code, so our nurses, the residents, pharmacies, and cardiology are all used to running a code, so many drugs were sort of considered, for which I then would give the final order to pharmacy.
Okay. What does that mean to run a code? What do you mean by that?
I was the final sort of say. It was sort of because there are a lot of people asking, can we do this, should we do this, there needs to be a final say to, yes, execute this order for the nurse, for pharmacy to prepare the drug, prepare the dose of the drug, then also to tell the nurse to, yes, administer the drug.
Okay, so when you say you were running the code, you were in charge of these efforts and in charge of the team of medical personnel?
Yes.
Okay. And you were aware that paramedics had given a series of starter drugs to Mr. Jackson, both in the field and also during transport, correct?
Correct.
Okay. And while at UCLA, were additional dosages of epinephrine given to Mr. Jackson?
Yes.
Okay. Was sodium bicarbonate given to Mr. Jackson?
Yes.
Was vasopressin given to Mr. Jackson?
Yes, it was.
And what is that?
It is another type of vasoconstrictive medicine, a different class of drugs than epinephrine that is given at times during the cardiac arrest.
And the purpose is what?
Our goal is to try and attempt to have the heart pump better, to constrict the blood vessels and achieve a better blood pressure to the brain, and to actually restart someone's heart.
Okay. And was dopamine given to Mr. Jackson?
Yes, dopamine was given as an infusion, as a drip.
And for what purpose?
Again, it's a drug that can increase the sort of the strength of the way the heart muscle contracts, as well as can increase blood pressure and increase heart rate.
Okay. And again, during these efforts then, was a technician on site doing physical chest compressions?
Yes.
Okay. And did that continue throughout this, throughout these efforts to revive Mr. Jackson?
From the time of arrival, I can't remember if it was actually when we did the, later on there was an ordered balloon pump, cardiology. I don't remember if we actually stopped compressions. In general, compressions are continuous and only stop briefly to check to see if there's a pulse or a response to therapy.
Okay.
There are brief interruptions.
Okay, and there's a technician actually assigned that responsibility to do two-handed chest compressions on the patient?
There is. There's more than one. People get tired, so we rotate to make sure that compressions quality is adequate and maintained.
Okay. And the care for Mr. Jackson, you indicated he arrived at about 1:13, and in fact was pronounced dead at 2:26 p.m. Is that accurate?
That's accurate.
Okay. So during that hour and 13 minutes, the care you described was pretty much continuous?
Yes.
Okay. And then these chest compressions from the various technicians at UCLA was basically continuous more or less through this hour and 13-minute
Yes, it was.
effort? Yes?
That would be correct.
And was there also a process by which Mr. Jackson was being, or bagging was taking place?
The respiratory therapist bagged Mr. Jackson throughout the resuscitation.
Okay, and what do you mean by bagging?
Mr. Jackson had an endotracheal tube, so it was a tube from his mouth through basically the windpipe into the sort of what we call the trachea, just above the lungs. That tip of that tube is then connected, there's a little connector, and there is what's called an ambu bag. And you physically squeeze that bag to deliver air, and in this case oxygen, because the bag is then connected to an oxygen source.
Okay. And that process, again, was continuous for this hour and 13 minutes?
Throughout, yes.
Okay. And there was a technician specifically assigned to that task?
A respiratory therapist.
And you've described in the various photographs the monitoring equipment. Was there cardiac monitoring taking place throughout?
Continuously, yes.
Okay. Measuring, what was being measured?
Sort of an EKG rhythm strip, a heart rate, attempting to measure blood pressure if there was a palpable blood pressure. Respiratory rate is monitored, so it would actually record how many breaths we were delivering. If there was enough perfusion that you could actually measure oxygen saturation, which is measured peripherally, that shows up on the monitor.
That'd be part of pulse oximetry?
That's a pulse oximeter, yes.
Okay. And all of this monitoring was continuous?
Throughout, yes.
Now, during this approximately hour and 13 minutes, did you ever feel or note a spontaneous pulse on Mr. Jackson?
I did not personally ever feel a pulse or confirm any pulse.
Okay. At some point, did you try to, was there someone in the room indicate that they thought they felt a pulse?
I think it was at 1:21, so approximately 8 minutes into the resuscitation, there was a report that someone, when we did a pulse check, reported that they felt a pulse.
Okay. And did you then stop compressions and see if you could confirm that?
When compressions are going, we could feel a pulse, but a spontaneous pulse without compressions, I did not appreciate. Around 13:21, I said, hold compressions, do we have a pulse? Someone reported feeling a pulse, at which point I attempted to confirm that. And the monitor still showed a slow agonal rhythm, which would not really be consistent with a regaining pulse. I then also confirmed the ultrasound, look at the heart to see if it was actually pumping in a manner that I thought was improved, and did not, and I could not palpate a pulse to confirm, and so chest compressions were resumed, and no other pulse was ever appreciated without compressions.
Okay. So through your own observations and the equipment you referenced, you were not able to ascertain a pulse at that time?
At any time.
At any time, correct?
Correct.
Is it common in these situations for people to feel for a pulse and actually feel their own pulse and mistake it for the patient's?
During a code, it would not be uncommon for someone to think they felt the pulse, and that is why we always confirm.
And that's why with all the equipment available, you can confirm through multiple means?
Yes.
Now, then at 226, did you make the determination to again pronounce Mr. Jackson dead?
Yes.
And that was actually the second time that you'd made that determination, the first one being at 12:57 p.m. when the paramedics were out in the field with Mr. Jackson?
That would be correct.
And from that time of 12:57 p.m. to the time of 2:26 p.m., had there been any notable change in Mr. Jackson's condition?
No.
Dr. Cooper, I noticed in the medical records, the patient identifying labeling system assigned to decedent Michael Jackson actually has a particular name, and I'll read it: Trauma WM0241, Gershwin, Gershwin. What is that reference?
For circumstances such as a code or say a trauma patient, a patient that's coming in that is critical, in which we need to be able to access medications, get an immediate chest X-ray, and immediately obtain sort of lab data, we need a system of labeling, and there's not time to register the patient. So we have pre-made packets that include a doctor's note, a nurse's note, or a code note, extra labels, stickers that can be placed on blood specimens, X-ray requests that are already labeled, so we can immediately begin to order treatments and link everything to that one record, so we don't make a mistake.
So these are labels that are created prior to even the patient's arrival at the hospital?
There are a series of packets that run in alphabetical order, and the next packet up is...
Okay. And that's so that there's no delay in creating these labels and record-keeping system when the patient's there waiting to be treated on?
Correct.
Okay. And so in the case of Michael Jackson, was the labeling system unique to Mr. Jackson?
The medical record ID number is unique to the patient.
Okay.
Because it's an alphabetical system, there will likely be another trauma Gershwin within a certain months, but each patient has their own unique identifying medical record number.
Okay, and that number is reflected in all of the medical records as well as your report in this case?
Correct.
Okay. May I approach the witness? I'm approaching with her handwritten notes. Is the label depicted, for example, on the first page of your handwritten notes?
Yes.
Okay, and does that have what I read previously, Trauma WM0241, Gershwin, as well as the accompanying medical record number?
Yes, it does.
Okay. And what is the medical record number that was assigned to all the records and blood samples of Mr. Michael Jackson?
397-5944, and there's a 4. But
okay. And the main sequence of numbers then is the 397-59-44?
that's correct.
Okay. And again, that's unique through all the specimens and the records for Michael Jackson?
Yes.
And information attached to blood samples that were collected from Mr. Jackson for subsequent analysis?
Yes, they would be.
Now, when Mr. Jackson arrived, or following his arrival at the hospital and your observations of him and his body, did you notice a condom catheter on his body?
Yes.
And what is that?
It's one type of urinary collection device in which there's a condom. At the tip of the condom, there's a hole that's connected to a tube, and that tube connects to sort of a collection bag system. It's to collect urine.
Okay. And from a medical standpoint, in a surgical room, are urinary collection devices in the form of catheters used because the patient is essentially unconscious and will need a collection device to collect the urine?
There are a number of urinary collection devices, and a catheter would be common in the OR and in other areas of the hospital.
Okay. Now, at the time that you observed that, you knew that Mr. Jackson had been coming from a home, correct?
Correct.
Okay. Did that strike you as odd to see this condom catheter on the patient?
I thought it was unusual. A condom catheter would not be uncommon in someone who has problems with incontinence, but it seemed unusual for a 50-year-old male who was reportedly healthy.
Okay.
Yes.
Now, following the pronouncement of death, Dr. Cooper, did you ever consult with or request Dr. Murray to sign a death certificate?
No.
Is that something you would have done in this situation?
No.
Why not?
Mr. Jackson was my patient, and I didn't really have an explanation for why he was dead.
Okay.
And it therefore, in my mind, was a coroner's case.
So when you say it was a coroner's case, you mean that it will be referenced to the coroner's office for an autopsy and investigation?
Correct.
Okay. So you never asked Dr. Murray to sign any death certificate?
No, it was not a discussion.
Okay. That conversation never even took place?
No.
These are double negatives.
Did that conversation ever take place with Conrad Murray?
That would be correct. I did not have a conversation with Dr. Murray about the death certificate, no.
And it wouldn't be his decision, it would be yours. Is that accurate?
That would be accurate.
Now, again, following pronouncement of death, was a social worker team gathered together to be available to the family and the children if necessary?
The social work team had actually been gathered even before the pronouncement. Social work was one of the team members who was notified of the code and was there at the outset, in part to help me assist contacting family, although that was apparently done through, I think, someone through Mr. Jackson's people. But, and I'm not sure when I became aware his children were there, but there was a social work, there was someone with the children separately. Yeah.
Okay. But this social worker team, was that assembled as part of the standard UCLA protocol in this type of situation?
Yes.
Okay. That was not Conrad Murray's doing. In other words, he's not the one that recommended or gathered together a social worker team, is he?
No, we would typically call a social worker when we have a code,
Okay.
and they are activated and
As a standard protocol.
as is protocol.
Now, at some point, did you learn, or were you told that the children had been notified of their father's death following pronouncement?
Yes, I was told.
And did you then personally go to check on the children or see if there's any information you could provide?
I did go to check on the children at that time.
And did you see the children?
I did, yes.
And what were they doing?
They were crying. They were fairly hysterical, being comforted by someone who was referred to as their nurse.
And did you hear anything being said by one of the children at that time?
There were,
The objection sustained. Calls for hearsay, absent further foundation. Partial answer sustained. Disregard.
What attempt to speak to the children at that time?
Sustained.
You described them as hysterical and crying?
Yes.
Thank you. Nothing further, Your Honor.
Mr. Walker? Thank you. Cross-examination by the defense. Mr. Flanagan.
Flanagan. You're supposed to already be ready.
Dr. Cooper, have you reviewed any documents prior to your testimony in this case?
I've reviewed my medical chart, and I did review the preliminary hearing testimony.
Reviewed your testimony at the preliminary hearing?
Yes.
Is there anything that you would like to correct regarding your preliminary hearing testimony?
There probably are things I would clarify if I had the testimony to go through page by page now.
But nothing you'd actually correct as being wrong?
I think there may be statements I made that may have oversimplified.
But nothing absolutely wrong?
I don't believe so.
Okay. As you sit here now, what is your best estimate as to the time of death, Michael Jackson?
I don't know when his actual time of death was. I know the pronouncement I made based on the information I had at the time I was involved in the radio call.
So at 12:57, you were acquainted with all of the details from the paramedics, and you formed the opinion at that time he was dead.
Yes.
And you wouldn't authorize a call to be made if you thought there was any chance of saving an individual, would you?
No.
So at 12:57, you knew in this case nothing could be done.
Based on the information I had, I felt a pronouncement of death in the field was appropriate at that time, yes.
Okay. The only reason that anything was done after 12:57 is because Dr. Murray insisted that you don't give up. Is that correct?
I don't know if I would word it that way, because as the base physician, I could override and still pronounce. However, there was a physician on scene, and then I had potentially conflicting information. And so, yes, I did authorize and allow Dr. Murray to assume control and then bring the patient to the emergency department or the local emergency department. So, yes.
But for Dr. Murray, he doesn't even get brought to UCLA Medical Center, does he?
That would be a correct statement.
Excuse me?
That would be a correct statement, yes.
And you basically felt when Michael Jackson was brought in, everything's going to be futile anyway. Is that correct?
My assessment when he arrived was that he was clinically dead. And given it had been now from the time that I had as the prior time of rest from the code in the base station form, it was about an hour, such that the resuscitation efforts would likely be futile, yes.
But if you thought there was a chance when he was in the field, you wouldn't have authorized them to call it, would you?
I'm not sure if I'm sort of saying something that seems to be conflicting, but I made a call based on the radio information that I had, which was from the paramedic report, and I did, at that time, he was clinically dead. I felt comfortable pronouncing him.
And when you wouldn't be comfortable pronouncing him dead unless you thought there was no chance. Isn't that correct?
At the time I made the pronouncement in the field, I made a decision based on the information I had, yes.
And the information that you had in the field proved out to be the same when they brought him in. Is that correct?
That's correct.
And so, the minute he comes in the hospital, there's no chance, is there?
In retrospect, after my evaluation and knowing everything I know now,
Right.
that would be correct.
And when you looked at him, when they brought him into the hospital and you actually got to use your own senses and eyes, you knew right then, there's no chance, didn't you?
When Mr. Jackson was sent to the hospital, Dr. Murray reported that he had felt a faint pulse, which conflicted the information from the paramedics. I therefore, yes, decided that it was going to be my decision to make sure that everything had been done, was done correctly, was not misrecorded, and that with effort there was no change. So, yes, I used my determination of what I saw to make a final decision.
And that confirmed the original decision that you'd made at 12:57, didn't it?
Yes.
At 12:57, based upon the information you have, would you have any idea as to the time of death?
No.
Now, you went to medical school, and then you became a resident, did an internship. Did you ever become an anesthesiologist?
No.
Do you use propofol?
I do use propofol in my practice in the emergency department, yes.
Is there any special certification that you have to use propofol?
Yes.
What is that?
At UCLA, you need to have privileges, first to perform procedural sedation, as well as specifically privileges to administer propofol.
So you're certified to use propofol for anesthesia purposes?
No, I am certified to use propofol in the emergency department for procedural sedation and for deep sedation of patients who are intubated. I do not perform anesthesia.
Are you certified to use propofol for conscious sedation?
We use the term procedural sedation, and yes, I do have privileges to perform procedural sedation using propofol at UCLA.
Have you ever practiced in a medical office?
No.
I take it you probably never made house calls either.
No, I am an emergency medicine physician. I work in the emergency department.
And so whenever you're practicing medicine, you're always in the confines of a medical room or a hospital setting.
A hospital emergency department, that would be correct.
You use the term procedural sedation. Does that differ from the term conscious sedation?
Conscious sedation is sort of an oxymoron. Right? You're not conscious and potentially sort of very sedated and unconscious. So we use the term procedural sedation for the reasons that we would be using these medications.
Well, in conscious sedation, when you sedate the individual, the individual is capable of being aroused, isn't it?
Sedation is a continuum from being completely alert to being comatose.
So you're not even familiar with the term conscious sedation?
The objection sustained of you in the earlier answers.
Okay.
Seems like he asking her the same
Is there a difference in
question.
being
He
certified
getting
for
on my
conscious
nerves.
sedation versus certified for anesthesia in the use of propofol?
So in terms, there is a difference in having privileges to perform procedural sedation than having privileges to perform anesthesia, yes.
And there's different requirements for monitoring with respect to the differences with respect to anesthesia and conscious sedation, isn't there?
For procedural sedation, there are very specific requirements for monitoring. I am not an anesthesiologist. I do not work in the operating room. I do not perform anesthesia, and so I'm not qualified to tell you what their requirements are.
Are you familiar with blood levels toxicology numbers that will be achieved upon use of certain amounts of medication?
No.
Beyond area of expertise.
Sustained, partial answer is stricken. Please disregard it.
So if a person's given a certain amount of propofol, would you be able to tell what their blood level was?
Beyond the scope, beyond the
Sustained,
Now, in your use of propofol and for procedural sedation, what types of what amounts of propofol do you use?
It will vary case by case.
Okay, it depends on the individual size.
Yes.
And does it also depend upon the level of sedation you're trying to achieve?
In general, once I make a determination I'm going to perform procedural sedation, I will choose a dose that will, in general, make patients comfortable and not be completely alert or aware so that we can perform whatever painful procedure needs to be done. So, in general, our goal is to have about the same level of sedation for most procedures.
Okay, do you ever vary the sedation level for a procedure that you do?
Yes, probably.
You ever used propofol as a pre-med prior to doing a procedure?
No.
Now, if I were to give you a hypothetical that 25 milligrams of propofol was slowly infused over a 3 to 5 minute period at 1040 with also 2.5 milliliters of lidocaine, would you have an opinion as to how long that would last?
It would depend on the patient.
On a patient, say, the size of Michael Jackson, about 135 pounds.
And he received no other medication.
Right.
I would think it would be, in my practice for procedural sedation, I couldn't imagine I would give a dose of 25 milligrams to an otherwise healthy 60-kilogram male and give it over 3 to 5 minutes, because I would not expect that would produce any level of sedation for me to achieve the procedure I wanted. But if it did achieve sedation, I would expect, if he didn't have any medical problems, 7 to 10 minutes, it would probably be worn off.
When you say worn off, what do you mean?
I would expect that I would not have, if I had achieved sedation, I would suspect that sedation would be completely resolved within about 7 to 10 minutes.
Would that mean that the propofol would basically be out of the bloodstream?
I don't think that would mean that the propofol would be completely metabolized, but the sedative effects that I would be concerned about and the sedation level would not be a concern at 10 minutes.
How long do you think it would take for it to be completely metabolized?
beyond the scope, beyond area of expertise.
Sustained,
Now, when you say you're not even sure that would achieve, if there's no other drugs in the system, that might not achieve a level of sedation. Is that correct?
That's correct.
So is what you're saying is that 25 milligrams is a very small amount of propofol to give a patient?
A 60-kilogram male, if I wanted to achieve sedation so that I could perform a painful procedure,
Yeah.
25 milligrams would not be a sufficient dose in most patients.
But it might be enough to put the person to sleep.
I don't suspect so, but I don't know. I do not use the medication in those types of doses.
Now, Dr. Murray informed you that he had given lorazepam. Is that correct?
That is correct.
And he told you 4 milligrams?
He reported he gave him 2 milligrams, and then at a later time gave him another 2 milligrams, and at the time of just before the arrest.
Did he tell you what time he gave the lorazepam?
did not get a specific time, no.
Did you ask for a specific time?
I did not explicitly ask for the exact time.
Would the time of the lorazepam matter?
What do you mean, would it matter?
Well, would it matter as to whether or not it's having an effect on his body at that time?
At the time Mr. Jackson was my patient, he already had been dead for some time. The dose of the medication was reported to me as being, the last dose was given at the time that Dr. Murray reported he witnessed the arrest.
Okay, when you asked about the medications, were you trying to determine a cause of death, or were you trying to get information necessary for purposes of treating Mr. Jackson?
The information I had about the lorazepam was provided by Dr. Murray when I asked what happened and was trying to obtain both the patient's medical history as well as the events surrounding the arrest so that I could treat Mr. Jackson.
So you wanted to know the information for purposes of treatment?
Mr. Jackson was my patient and I was attempting to treat him, yes.
Okay, you were not looking to determine a cause of death?
I was looking to determine what may have caused the death, just as the same reason I asked about past medical history and medical complaints, because I use that in my decision-making in determining if there was something that was or was not done during the resuscitation that I should do.
Well, when he's treated with lorazepam, would it make a difference whether it was treated, whether he was given the lorazepam that morning or the following or the previous day?
Matter in terms of, I'm not sure what you mean in terms of matter.
Why did you ask what medications were there?
I was attempting to resuscitate Mr. Jackson. So in my mind, as I am running the code, I am thinking of all the causes for why a 50-year-old male would be suddenly dead, so that I could then decide what treatments we should consider.
Okay, so the medications are important to know, but the time of those medications is important also, isn't it?
Most of the history would be important. That is why I asked Dr. Murray for information.
But you never asked him about the time, did you?
No.
Okay, so if he gave lorazepam the day before, it wouldn't matter at all, would it?
I don't know what he did the day before. I became Mr. Jackson's doctor when he arrived in the emergency department, and I was asking for a medical
No,
history.
I'll allow the witness to finish. The objection is overruled. You may answer, please.
The medical note that I wrote is the story of the care that I provided and the information that I had at the time. I asked Dr. Murray standard, simple questions that I would ask of any medical professional if I was taking care of their patient.
You determined what the medication was that had been given. Is it your testimony that the time that it is given did not matter?
I don't believe I said that that was my testimony, no.
No, you didn't. I'm asking you if it did matter.
It may have mattered, yes. At the time I was taking care of Mr. Jackson, I didn't know why he was dead, so I wasn't sure what mattered. That's why I asked for all of the information that I could have.
But you didn't ask about the time, did you?
No, I did not explicitly ask for the time.
And what I'm asking you, does the time matter?
Objection asked and answered about 3 times.
Overruled. You may answer the question.
At the time I spoke with Dr. Murray, his report to me was he gave, at the last dose, he gave 2 milligrams of lorazepam, observed the arrest, instituted CPR, and called 911. In my mind, I made the assumption, which may be incorrect, that that was all proximate, that he had just received the medicine, he witnessed the arrest, and then the patient shortly became my patient.
Now, you've never testified before that he gave it and then witnessed the arrest right after he gave it, did you?
I believe I did testify to that, and I believe that's what my chart reflects.
Well, if Dr. Murray gave lorazepam 2 milligrams at 2 o'clock and 2 milligrams at 5 a.m., would you still expect that to be in the Michael Jackson system at 12?
And when you say in the system, I don't know what would be completely cleared in terms of metabolites, but a dose of medication at 5 a.m., I would not expect to have as much of an effect at noon.
We're not communicating very well, Doctor. I asked you a question. 2 a.m., 5 a.m., 2 milligrams each time, would you still expect that to be in his blood at 12 o'clock?
Beyond your area of expertise.
If you know or not.
I do not know when the drug would completely clear his bloodstream.
Overruled.
Are you familiar with the half-life of lorazepam?
The half-life of benzodiazepines can vary greatly depending on the patient and on how many doses they've had, on whether they're a routine user.
I'm not talking about benzodiazepines in general. I'm asking you if you're aware of the half-life of lorazepam.
I cannot give you the exact half-life of lorazepam currently, no.
If it was given 2 milligrams at 2 and 2 milligrams at 5, would you expect any lorazepam to be in his bloodstream?
Sustained.
You're not familiar with that? What?
Overruled. Is that a fair statement? That you're not familiar with that particular issue?
I'm not.
Too many variables and whatever else is going on?
It seems to be still related to something in the blood level and the blood system, and I'm not qualified to answer that.
Thank you.
Okay. Now, if Michael Jackson was slowly infused with 25 milligrams of propofol at 10:40, would that still be in his blood system at 12?
Same objection beyond the scope, beyond your area of expertise.
I think she's familiar with this.
I'll overrule the objection if you're able to answer that type of hypothetical.
I think you were asking if something was still in his blood system, and as I said, I do not know the metabolism of blood, but I would not expect him to still be sedated from that 2 hours later, if that's the question.
Well, you know it wouldn't be in his system, don't you?
Sustained.
What type of training have you had with respect to the administration of propofol?
I have been to courses on procedural sedation. I perform procedural sedation. We routinely review articles for the use of procedural sedation.
Okay. And if you're going to do procedural sedation on a 135-pound person, 60 kilograms, how much propofol would you use to sedate them?
So this is an otherwise healthy person who I've already decided is safe to give procedural sedation to,
Yes.
and I've not given them any other medication.
Yes.
About 1 milligram per kilogram would probably be my starting dose.
Okay. And that if you gave him 1 milligram per kilogram, in this case that would be 60 milligrams, correct?
Correct.
How long would it keep him asleep?
If that was sufficient to sedate him, I would suspect the level of sedation would wear off in about 10 minutes.
Okay. How long would it continue to be in his system?
Same objection.
Same ruling on foundation grounds. Sustained.
How long would it be detectable in a blood sample?
Sustained. We're going to move to another subject area. Thank you. 350, 352.
Would it be your testimony that you're not... Well, let me ask you about this propofol. Dr. Murray told you that he'd given 25 milligrams of propofol at 10:40, sometime between 10:40 and 10:50. Would that have altered your treatment of Michael Jackson?
No.
Would that have altered the result that happened to Michael Jackson?
As I said, Mr. Jackson died long before he became a patient that I was personally responsible for. So, no. Knowing even more information, it is unlikely with that information I would have been able to do something different that would have changed the outcome.
And when you asked about the medications, interested in medications that might be in the system at that point in time?
I was interested in all of the available medical history so that I could best decide how to treat Mr. Jackson.
But there was no chance of treating Mr. Jackson, was there? Successfully.
From what I know now, no. But at the time, I had a 50-year-old male who was dead, and in my mind, there are many other conditions that may cause a cardiac arrest. I therefore asked information on the history so that I could either consider those diagnoses or other treatments.
In your use of propofol, you ever had a patient with slurred speech?
Someone who's...
I'm going to sustain the objection. 350, 352. Strike out the answer, please.
Did you see or listen at any point in time in the last week Michael Jackson's speech on May 10th at 9:05 a.m.?
Sustain. 350, 352.
Can we approach on that one, Your Honor?
Yes.
Months or pushed over a period of time?
Not specifically.
And you've never seen it done?
Not in my practice, no.
And you've assisted other doctors, and you've never seen it done where it was pushed all at once, have you?
Now, when we do procedural sedation propofol, I am usually the one to push and administer the medication. If I am teaching a resident, I instruct the resident on how to administer it.
And when you're instructing them, do you tell them what the consequences could be if it was pushed all at once?
If a patient, in reality, if a patient is oversedated, I can manage it, but our goal is to sedate the patient to do the procedure. I do not give a lecture on if you push it all at once, what happens, if that clarifies.
So when you're training the residents in the administration of the propofol, you don't tell them why it's got to be done over a period of time.
With most things I would describe, we want to get the level. We do actually want to get the levels up to a high level fairly quickly, as opposed to over a protracted period of time, because you want to achieve a deep enough sedation level to achieve the procedure.
Well, when you say you want to get the levels up fairly quickly, is that what you're describing when you talk about a minute to a minute and a half?
Mm-hmm. Yes.
Okay. Why don't you want to do it quicker than that, like get it up in 5 seconds?
Because I may not need to give the full dose of drug that I've administered, because as I give the medication, I can determine how the patient's responding. So if the patient is having an adverse reaction, I have not given the whole dose of medication.
So the only reason you don't give it in a bolus push is because you're not sure how much the patient needs.
Well, I also give it over a minute to minute and a half, because that's the general instructions of how to use the medication.
And you don't know the reason for the general instructions to do it over a period of time. Do you know the reason why you're instructed to do it over a period of time as opposed to all at once?
I reported this is why I do it, because I want to see the response and see how sedated the patient becomes.
And that's the only reason?
What other reason specifically?
Would it be dangerous to do it all at once?
Jackson asked and answered. So overruled. You may answer.
I suppose if you could get such a level that was so high, especially if you were giving a large dose, yes, that would potentially cause more sedation than you anticipated, or deeper sedation.
Okay. Well, the 60 milligrams that you use, if you did that all at once, would that be dangerous?
Section vague speculation.
I'm going to sustain the objection on 352 grounds. And allow counsel to reopen. We're approaching the limit. Thank you.
Now, whenever you use propofol, you typically have all of the equipment that's available in this surgical suite here, or this trauma bay center?
This trauma bay has a number of other equipment and modalities that are not really relevant to procedural sedation. So no, I do not have all of that available to me.
Okay, but you've never given propofol outside of a surgical setting, a surgical suite?
I do not work in a surgical suite. I work in an emergency department.
Okay, and the emergency department has basically all the stuff you have in a surgical suite, doesn't it?
I can't speak to what is in a surgical suite. In the emergency department, I have monitors in every room. I do not perform procedural sedation in a room that does not have a monitor. And when we perform procedural sedation, we have airway equipment in the room and set up, because that is our policy, to have that set up before we start any procedure.
When did you start administering propofol? In terms of year?
I'm going to sustain the objection on 352 grounds at this juncture. Thank you.
All this equipment that you've identified up here in this trauma bay, such as those computers where the IV bags might hang,
Yes.
how long have they been there?
Sustain.
Is this new equipment?
All right. I'll overrule the objection. Go ahead, please.
Everyone at work is going to wonder why I don't know this. I don't know exactly when we moved into the new Ronald Reagan Hospital, but a computerized pump or a pump is something that is standard in practice in the emergency department. And in my entire career, through my training, we have pumps that we can control the rate at which medication flows, whether it was computerized or what type of a specific brand or if it was that machine. I couldn't tell you how long.
Whenever you administer IV medicine, is it always through a pump?
No.
In administering propofol, has it always been through a pump?
When I administer propofol in procedural sedation, it is not through a pump at all. As I said, I administer it myself slowly as a push.
That's just with a needle.
We use a needleless system, but yes, it is connected to the HEP lock.
And that's that little lock on the IV tubing that goes to the patient?
The patient will have a catheter, a tube in their arm. At the end, there is a cap. I will connect to that cap it's a wireless, needleless system that we will connect through. There's sort of like a rubber hub. I will then infuse the propofol that's in a syringe that I've drawn up through the IV.
So you don't use those pumps for propofol at any time?
Objection to stated testimony.
Sustain.
What are those pumps used for?
Those pumps are used to control the flow of medication and the rate of medication for it. So it would depend on the type of medicine and whether it needed to go in over a certain period of time. Or if someone was on a continuous infusion and we wanted to control that infusion.
Do you use propofol on a continuous infusion?
In some rare circumstances, yes.
It's not normally used for procedural sedation that way, though, is it?
That would not be procedural sedation. That would be used for deep sedation in a patient who has been intubated and is on a ventilator.
Okay.
Mr. Flanagan, thank you. On redirect, please.
Thank you. Dr. Cooper, in deep sedation, where you're going to have a continuous drip or infusion of propofol, you would rely on the infusion pumps, correct?
Correct.
Okay, and those would monitor precisely the dosage, the amount of propofol flowing into that individual's body, correct?
Correct.
Okay, now you indicated that when the patient was over-sedated, you're able to manage that situation. Do you remember that answer to Mr. Flanagan's question?
Yes.
Okay, and the way you're able to manage that situation is because you're in a hospital setting with all the necessary emergency equipment and airway equipment to manage that type of consequence, correct?
Correct. And I'm an emergency physician, and so I have the skills to intubate a patient and to actually obtain an airway if that is so necessary. Yes.
Okay, and you're prepared for that consequence?
Yes.
Thank you. Nothing further, Your Honor.
Thank you. Any on Wheatley Cross, Mr. Flanagan?
Have you ever,
Yes, please come to the podium.
have you ever used...
Wait, if you could just wait till you get to the podium, please. Thank you.
I'm sorry, Your Honor.
That's okay.
Have you ever needed to use those skills during a procedural sedation?
Overruled.
I've never needed to intubate a patient, but yes, I have needed to attend to a patient's airway during procedural sedation.
And in attending to a patient's airway, what have you had to do?
The first thing you'll do is stimulate the patient, because if you can wake the patient up and they're just not breathing, usually you will catch it before they stop breathing. That is the goal. I've never had anyone stop breathing during procedural sedation. But generally people's breathing is insufficient. So if I can stimulate the patient, they will generally take deep enough breaths. That, with oxygen and repositioning the airway, is almost always sufficient.
And if a person had a problem when you were administering the propofol, it's something you would see right away, isn't it?
Yes, that's why you are monitoring them, why me as the physician and the nurse is monitoring the patient.
So if you took 60, I think he said 60 milligrams for a 60-kilogram patient, and you started administering it, you could see if there was a problem developing right away, couldn't you?
Typically, yes.
And what would the signs be that the problem was developing?
A problem of oversedation? Is that the question? Because there could be other problems, an allergic reaction, some other unexpected reaction.
Okay, well, you've never seen those happen, have you?
I usually screen patients so that I do not perform procedural sedation in someone who may have a problem, may be allergic.
Is that a no? You've never seen that?
Other reactions? No.
Okay. Now, the one problem that you could, that you might see would be a breathing problem.
The common problem, the first problem you'll see will be oversedation, which would result in respiratory insufficient breathing. Yes.
Okay, you could determine that by just seeing the patient, couldn't you?
When you're doing a procedure, you may miss something when seeing the patient. That is why we have a monitor that monitors their pulse oximetry, capnography, which will pick it up often before humans will detect or notice there's a problem.
But you shouldn't actually be doing the procedure and controlling the propofol also. So that's for separate people, isn't it?
That's why there is a separate person to perform the procedure, and I, as the attending, attend to the procedural sedation.
Okay, so when you administer the propofol, 60 milligrams, you wouldn't be doing the procedure also.
No.
You would just be concentrating on the patient.
Yes.
And if there was a breathing problem, you could readily determine that, couldn't you?
Yes.
And you could readily determine it by just looking at the patient, couldn't you?
You still may miss because people who are sedated will breathe less, but if you're breathing 8 times a minute as opposed to 16, that may be sufficient. Versus if you're breathing 8 times a minute and you're not breathing deep enough, your oxygen saturation may start to drop. And even watching the patient, there are potentially problems that you will miss. That is why we monitor as a fail-safe, and we have 2 people monitoring.
Well, when you say you could miss it, you could miss the first sign, but you would see it within a couple minutes, for sure, wouldn't you?
You would see it before a couple minutes.
And so if a person was infusing over a 3 to 5 minute period of time, 25 milligrams, and there was a problem with that, that would be easy to determine, wouldn't it?
If you're asking me, if I was watching a patient and monitoring them, and they had a problem, would I notice it, or would the computer or the monitor alert me to there being a problem while I'm doing my procedural sedation? Either me or the monitor or the nurse who was monitoring the patient would identify the respiratory depression before it became a problem, yes.
I mean, and you would identify it without a monitor, wouldn't you?
I would hope I would. would, but I have a monitor and an additional person so that I do not miss it, because that is the danger in performing procedural sedation and why it is restricted.
Okay, and the answer is yes? You would determine whether there was a breathing problem without a monitor?
It misstates the evidence. Sustained.
Could you determine whether there was a breathing problem if you didn't have a monitor there?
At some point, yes, you would notice that the patient is not breathing. The monitor is detected early, and or if for some reason you did not detect it.
And a pulse oximeter would detect that, wouldn't it?
Pulse oximetry is a late finding because it takes time for your oxygen saturation to drop. And in fact, by the time your pulse oximetry is dropping, you have missed that the patient is insufficiently breathing.
Okay, and how long would that delay be?
Just a moment, please. I'm going to sustain the
Okay.
objection. At this point, I'm with 352.
If you have no monitors whatsoever, and you're putting propofol in a patient, what's the outside that it would take you to determine whether there was a breathing problem?
Objection. Improper hypothetical.
The objection is sustained. It presumes and assumes that she would undertake that procedure.
I'm not assuming she would do it, but I'm asking if she didn't have monitors to rely upon, how long would it take her to determine it?
That presumes that she would undertake the procedure. You can start off with that question, please. Sustained. It's an incomplete hypothetical.
Whether or not you would do it, doctor, would you be capable of detecting a breathing problem?
Objection. Relevant. Asked and answered.
Sustained.
Nothing further, Your
Mr.
Honor.
Flanagan, thank you. Anything further, Mr. Wallner?
No, thank you, Your Honor.
Thank you. May Dr. Cooper step down and be excused subject to recall, Mr. Wallner?
Please, Your Honor.
Mr. Flanagan?
Yes, Your Honor.
Thank you. Dr. Cooper, thank you for your testimony. Please don't discuss either your testimony or the facts of the case with any other witnesses until we finish the trial. And while you may step down and leave, you want to remain on call, and that means you're subject to recall. Thank you.
Thank you.
You're welcome. The people may call their next witness, please. You may.
Thank you.
Juror number 7? Mrs. Theodore usually has them available. We can get one for you. Oh, you spotted it yourself. All right. Mrs. Theodore, could you? Yes, just wait one moment, please. Yeah, got too much stuff going on here right now. May we approach? Counsel? Inconvenience you any further. We're going to take the mid-morning break at this time. It's 20 minutes after. We'll take an approximately 15 to 20-minute break. Of course, please remember all the admonitions in writing and verbally. Enjoy your break. We'll see you in 20 minutes. So we'll pause you. Watch your step, please. Juror 7, if you want an extra tissue to go ahead.
not seeing nothing on the computer, just
Okay.
around.
It's still recording.